we don't know most things about endometriosis. You're talking about progression. We don't even have any evidence that it is a progressive disease.
You no longer need surgery to be diagnosed with endometriosis. Here's what's changed. That is the title of an article that was recently published and created quite a discussion on social media. So I decided to go straight to one of the co-authors, Dr. Mike Armour, to better understand his perspective and what the article really meant to say. And we did this conversation as a Zoom call rather than my typical podcast equipment because it was really just a get to know you conversation. And luckily, I asked in the beginning if I could record the discussion, and we decided it should become the podcast episode. So take a listen to this insightful conversation about endometriosis.
I have had, a reasonably unusual journey. So I originally trained as a cardiovascular biophysicist, which sounds much smarter than it actually is. And I worked on heart disease. I was kind of bored with that. It was, mostly working with animals, and, I always wanted to really help people. So I left doing that, and I changed completely and went and studied acupuncture and Chinese medicine. So I did a degree in acupuncture and Chinese herbal medicine. And then at the same time I was doing that, I've always been interested in research. So I was working as a researcher in the emergency department in New Zealand. So I'm a Kiwi, even though I live in Australia. And so then when I finished my acupuncture degree, I went into clinical practice. And one of the things that I found really interesting is when you are a student, an acupuncture student, or any kind of medical student or naturopathic student, you generally have to ask all of the questions. So when we do our training, someone comes in with a sprained ankle, you're still asking them about their diet, and one of the things we always asked was about the menstrual cycle. And I would say to women, how's your menstrual cycle? Oh, it's normal, it's fine. And then we do the traditional questioning, pain and duration and heaviness, and often more often than not, I'd be like, well, I'm not sure that is normal, really. And then what I started to notice was sometimes, we'd be treating someone for something else, headaches or some other condition, and they'd mention in passing, oh, my periods got better, by the way, they're less painful, or something like that. And so it got me very, very interested in a couple of things. Firstly, how effective Chinese medicine could be in treating menstrual disorders, but also, surprisingly, how so many people didn't seem to realize that, painful, heavy periods were not actually normal. Very common, yes, but not normal. So I guess that piqued my interest. And then the last bit that happened is my girlfriend at the time, who's now my wife, had really bad period pain when she came off birth control. And, I was quite obviously, with quite a strong scientific or medical science background. I was like, oh, well, this will be easy to take care of. We'll just go and we'll, get the right medication and it'll all get sorted. And I was quite shocked to find that that wasn't the case. It was really just non-steroidal anti-inflammatories all go back on the contraceptive pill. And we were trying for a family. Well, we were starting to try for a family. So obviously the latter was not an option. And I was quite shocked about, she had very severe pain. And we just couldn't get anything which would help it. I was in clinical practice at that time, and I decided that I would undertake a PhD because I was really interested. I always knew that I wanted to go on and do more research work. So I did my PhD through Western Sydney Uni, and it was in primary dysmenorrhea, so period, for lack of a better word, uncomplicated period pain or physiological period pain. After I finished my PhD, I got a job offer in Australia to work as an academic, and so moved from New Zealand to Australia, and I've been here for almost 6 years now. And so now I'm most of my work is, I guess, it's split between endometriosis and chronic pelvic pain, and I do a lot of work still on primary dysmenorrhea and especially menstrual health literacy. So, how do we make sure that young people have the information they need to understand what's going on with their body, how to manage their periods, and also, most importantly, do they know where to go and what to do if things are, not normal. And how do they know things are not normal? So I'm the chair of Endometriosis Australia's Research Committee, and I'm also the chair of their Clinical Advisory Committee. I'm a World Endometriosis Organisation Ambassador. I'm the chair of the Australasian Interdisciplinary Researchers in Endometriosis, or AIR. I'm also the academic lead for the Menstrual Cycle Research Network.
Wow. What's interesting to me in this women's health space is, to be honest with you, sometimes I wonder if there's a huge gap between what the researchers know and what doctors are doing.
It's quite possible, especially for primary dysmenorrhea, I think. It's really interesting because obviously, what we know in Australia is that over 90% of young people under 25 report regular dysmenorrhea. And it's severe enough that about 30% of those miss school or university on a reasonably regular basis. And, perhaps unsurprisingly, there's issues with, having to take time off work, and also what we call presenteeism, which is basically, you're sitting at work, but you feel like crap. And so you're not very, productive. And it's like, anyone who goes to work with a cold or the flu, it's the same kind of thing. You're physically present, but, you're not really able to work to your normal capacity. So I think, for most GPs that I know, primary dysmenorrhea, they tend to follow the guidelines, which is not bad, so the first line of treatment is non-steroidal anti-inflammatories, second line of treatment, or first line if they want contraception as well, as a combined oral contraceptive pill or some kind of contraception. So those are not terrible, they are the current guidelines, and there's evidence to support that they work. But what we find is that they don't work for a lot of people. They really don't work that well.
Right.
Or they work partially, and there's lots of complicated, reasons for that. Some of it is that people don't take the right dose, so they underdose themselves. They're worried about taking medication. Sometimes it's not taking the right kind. So many people take paracetamol, which I think is acetaminophen for you guys. And that's hasn't been shown in the research that it's effective at all for period pain. It's no better than a placebo. So lots of stuff. So I think that part of the problem is that when people go to their GP, and often they're told, well, you'll grow out of it. It's just normal. It's part of being a woman. Yes. Most people's mums have, because it's so common, although Google is becoming more popular now. But, when they say to their mum, I've got period pain, most often mum's going to say, well, don't worry, I had period pain too. It's normal. So you get this strong kind of normalization. And then they go and see their GP, and often their GP is like, oh, it's normal. We'll give you some painkillers. And then, if that works, fantastic. But if it doesn't, unfortunately, a lot of the time that's where things seem to kind of grind to a halt. And obviously that's incredibly problematic for those with endometriosis, who also usually present, for period pain for the first time. So there is a big gap, and there's also a big gap in, I think, what can be done from a non-pharmaceutical point of view as well, to manage primary dysmenorrhea. So there's some good evidence to suggest that, different types of exercise, not while you've got period pain, that's a bit cruel, but, exercise done during the month, and that can be something as gentle as yoga, or, right up to kind of going to CrossFit, depending on your inclinations, has been shown to reduce pain. There's obviously acupuncture, there's herbal medicine, there's diet changes or supplements. So I think, that's a really key part, is that there's a lot of information out there which is not getting to the people, like you say.
Do you know by chance for dysmenorrhea, what % tend to have endo? Do we know that?
Not really, but I think, we, like I say, it's about 90% have dysmenorrhea, about 11% in Australia have a diagnosis of endometriosis by the age of 44. So you're probably looking at, it's probably about 1 in 8 to 1 in 9. So it's, it's common.
Now, it was interesting, because the article, I will say, with what I keep hearing about endometriosis is it's really hard to find. And a lot of the surgeons that I've spoken to said it took me like 200 surgeries to properly find endo. And, but there's also the, just because you have it, do you have to take it out? So there's this whole, like, I was joking, like, can you draw a decision tree for endo? And it's like, no, it's more like a web, a cobweb.
Yeah.
And so if one read the article, I think the title felt so jarring that it created this crazy reaction on social media.
Yeah, so I think, I'm not sure if most people know, but obviously we don't choose when people write an article, whether it's for the conversation or whether it's for, a news piece, it's not us that chooses the title, it's the editor. And so, we actually pushed back to the editor and they said, we think it's accurate. And so we're not going to change it. And technically, they're right. It is true. It's just we wanted, can't remember, we wanted to add one or two words.
Right.
So I think, obviously it's important for them to get their clicks. And so, they put these kind of headlines. So I think probably the most important thing is that what we were talking about, obviously, is diagnosis. Diagnosis and treatment are not the same, and they don't have to be. And part of the argument we're making is maybe it's not always a good idea that they are the same thing. And so that's part of the ongoing discussion is that, should diagnosis and treatment come in the same package? Should it be the same day or shouldn't it? What I've heard from a lot of surgeons is that having more information before you go in is vital. The more you know about what's happening inside before you cut someone open is really important, because especially with endometriosis, most endo surgeons might not be comfortable opening someone up, finding, okay, there's a lot of deep invasive or deep infiltrating endometriosis. The bowel is involved. You need a bowel surgeon to treat that. Unless they know that that's there, there's not a bowel surgeon kind of just hanging out, in the operating room waiting to do their thing. So, that can mean then that obviously they will do their part, the surgery's done, and then they'll go back for another surgery with the bowel surgeon. And every surgery, we don't want more surgeries. We want fewer, the fewer surgeries, the better, because obviously not only is there risk and cost each time, but, it seems like the more surgeries you have, the worse outcomes really over time. And that's what there's some preliminary data to suggest.
Yes.
Kind of, more is not better, less is better in this case. So
is it true that if someone gets surgery at a younger age, they're more likely to not have progressive endo, and those who wait tend to have a worse, like, I haven't heard data on that, but empirically with the stuff I hear, I don't know if it's the way people twist the story, and based on the stories you hear, it suddenly becomes the data. But I'm curious if you have any facts around that.
We don't know. We don't know most things about endometriosis. So unpicking your last sentence, you're talking about progression. We don't even have any evidence that it is a progressive disease, so we assume it is, but actually there is no real, so far, beyond kind of anecdotal evidence of seeing progression in some patients. We don't have the data to say, yes, it's progressive. We don't have the data to say, and this is part of the massive issue, I think, with endometriosis and the discourse on social media, is that there's a big disconnect between the surgeons, the patients, or the people with endo, the researchers. A lot of the stuff that kind of comes up on social media is presented as fact. It's a lot more nuanced. I think this is part of the problem, is that we don't have a lot of data, for a condition which is so common and so devastating. We know very little about this. We don't have this longitudinal data, which is what you have for most other conditions, where you say, okay, someone, we need to get in by age 18 and then they'll have better outcomes. And the data we do have is kind of conflicting. So there is one study which showed that using birth control early on in adolescence seemed to result in less endometriosis, when they had less requirement for surgery, and when they had surgery, less endometriosis later on. and that's counter, but then on the flip side, you have a lot of people on social media saying, I was put on birth control, it didn't help, and, things just got worse and worse and worse. So we've got there's a huge disconnect between, the research and what people are reporting. And this is really difficult because obviously there's lots of biases,
yes.
And things. And this is why we do, clinical trials and why we do observational studies and things like that, because it's hard to judge, based on, what people are reporting on social media, how things are going. Because obviously if you are put on birth control, for example, and it does work and your symptoms do reduce, you're probably not going to be talking about it so much on social media
True.
as someone who is still suffering.
Right.
And so it's really hard, to say many of these things, because, it's hard to say who is the representative sample. Is it the people who don't respond to this, or is it the people that do respond to this?
Right.
So that's where it makes it very, very complicated.
Okay.
The discussion around surgery has become so, again, that's where we see the really big disconnect between the research and social media. And I don't know how to bridge that gap.
And also, have you done research on whether or not endo is an autoimmune condition?
Leah Hechtman is doing some of that in her work. Her PhD is looking at some of that. It's definitely, I would say it's not a well accepted, it's certainly not a mainstreamly accepted concept at the moment. But the answer is, really, we don't know what causes endometriosis. There's multiple competing theories. It's like, and again, this kind of comes back to, is endometriosis a single disease? Is stage 1 mild endometriosis, is it the same disease as deep infiltrating endometriosis? Is it, and, that's where it comes back to, is it progressive? Or is stage 4, the deep infiltrating, is it always going to be that? Is it a different phenotype? Is there something that causes it to be different? So it's likely that endometriosis, I think, based on speaking to people who are much more knowledgeable in this area than I am, is that it's likely to be quite a multifactorial cause, multiple pathways, and multiple phenotypes. And so probably more similar to cancer, I guess, in a way where there's lots of causes for this one overarching disease. Because we don't know what causes it, this is where, obviously everybody wants a cure, and which is totally understandable. That's what we all want. But it's hard to cure something when you don't know what causes it in the first place.
I agree. So back to the diagnosis versus treatment. So are you getting at that ideally you would be able to diagnose without the laparoscopic surgery and go in only if needed? But what about those cases where the endo is hard to find unless you're that expert?
Like you say, it's really problematic because people, I think, want a set answer. You should have this. But, every surgical, gynecological surgeon I've spoken to said that is a decision for the person to make in conjunction with their gynecologist, and so this is where, often on social media, the idea that everybody has to have surgery, that's really, firstly, who's going to do all of these surgeries and where are we going to do them? I think that's a lot of this comes from, I think, some, maybe a misunderstanding or how, again, I can't speak to America, but how the hospital system in Australia and New Zealand works is to do a laparoscopy, you need a surgeon, you need an anaesthetist, even for just a diagnostic laparoscopy. That has to be done in a hospital. You are not the only person who wants that operating.
Right.
So it's not a lack of surgeons in Australia necessarily, which is the problem. It's that there's only so many people that can go through the hospital system. There's only so much space. So anything that we can do to rule, I guess what we're trying to say is, if you can use another tool, a non-invasive tool like ultrasound, that's really helpful.
Okay.
But we shouldn't be saying, and I think we make it clear in our article, ultrasound should not be used to rule out endometriosis. Yeah. But if you can have something where instead of having to, part of this big diagnostic delay is many surgeons and doctors are understandably reluctant to do surgery, for the risks, the costs, but also even if you say, okay, I need surgery. I think you have endometriosis. We're going to do a laparoscopy. You might be waiting 4, 6, 9 months, in Australia. And that's, and then COVID delays on top of that.
Yep.
So I think what we're trying to say is if there's another way, if there's a biomarker, if there's ultrasound, and we can say, you have endometriosis, we can see it, or we can identify it, then you can start your planning process much, much earlier. And then if you want to have surgery, fantastic. But also it means the surgeon, if we can get the ultrasound data, the more data the surgeon has before they go in, the better. If they can be like, oh, you know what, this is quite superficial. I know how, like, the kind of things I'm going to need to do. I can prepare for that. And if they like, okay, this is a very, very advanced, case of deep infiltrating endometriosis, the bowel is definitely involved. I'm going to need a bowel surgeon. This is going to be a major operation. The more information from surgeons that I've spoken to, the more they know before they go in, the better. So that's really, I guess, what we were trying to say is that, and again, the holy grail really is a blood test, or a saliva test. If we can do a blood test and say you have endometriosis, or there's a 99% chance, that's fantastic. Then we can say immediately, right, what do you want? Here's your options. What are we going to do? Because most of the time, I think for most people with endometriosis, what they want is not necessarily a diagnosis. What they want is treatment. They want to feel better.
Yeah,
and diagnosis is obviously a crucial part of that. But if we can say, you have endometriosis with a 99% chance you have it. Okay, what do you want to do? Here's your treatment options. And then they can say, well, I'm not, some people might say, right, I want surgery straight away. Great. But many people don't necessarily want that straight away. They might have more mild symptoms. So it's about empowering patients to make those choices.
You know about the BCL6 marker, right? The Receptiva DX test. Have you heard of that?
Yeah, I think most of the ones that I'm aware of, they always do quite well in controlled samples. It's when you have to go to a large population, with different presentations, different, very diverse ages and ethnicities and things like that. That's unfortunately so far, that's when I've seen they all tend to kind of fall apart at that stage.
Got it.
Most endometriosis researchers, I'd be really happy to be put out of a job. If there's something that, comes along and changes things, fantastic. I would be more than happy to do something else. Every endometriosis researcher I know, every clinician I know, we all want the same thing.
This was wonderful. Like, the work that you're doing is amazing. And I guess one thing I will share with you just to get you thinking about this is I'm trying to figure out the value that I can bring to the table and putting these pieces together, because the podcast, it's basically what is the episode people are going to listen to. But because I'm hearing so much from so many conditions and so many experts, I'm seeing themes that run across all of them, right?
Yeah,
and by day, I'm actually a consultant for the healthcare industry. So the podcast is my side pet gig. And I do want to do women's health full time. And so I've really been spending the past couple of years in doing this podcast, trying to figure out how can those pieces be put together to create a clearer journey. And I kind of see the pillars of what needs to be done, like the research pillar, the education pillar.
And just while we're talking about that, just another project that I'm leading is we're working on a project called Endo at Work, which has just started. And that's actually looking to develop workplace policies in Australia for a variety of industries to help support people with endometriosis at work. We will talk about leave and we'll address leave, but it's more, what can we do to support people so they can stay at work, in work, do what they love, do what they want to do, not just saying, well, you can take time off, which is important and, relevant for many people, but also saying, well, how can we support you to be able to be at work? What do you need? Do you need to be able to take breaks more often? Do you need to be able to, work from home more? Do you need to have more ability to manage your own calendar, being able to reschedule meetings and things like that? So if you wake up in the morning and you're having a pain flare, would it be helpful to be able to say, you know what, I need to push everything back 2 hours, while I get this under control. So it's about, what do people with endometriosis need to thrive?
That's awesome. I'm starting to see some of that in the US too, but I will say I do find Australia is way ahead of the game on things like this.
I think New Zealand is probably usually way ahead of the game, even more than Australia, except in this case, because I think smaller countries, New Zealand's also very progressive.
Yes.
But we're small, small geographically, but small population wise. So I think there's much less layers, so I think it's just easier to get things done.
I have to say I'm grateful for the controversy, because then I wouldn't have met you.
I think, it's a shame. It is a shame about the controversy in a way, because I do think there's a disconnect there, which I don't think is in I'm not sure this would happen, I guess, in real life. It would be great. And that's why, I was happy to talk to you about it, because I think it'd be great to have a conversation, and kind of, I guess, realize that we are, all trying to achieve the same thing. And sometimes the human aspect is lost a bit.
Yes.
On social media, Yeah. So
I would agree.
Yeah.
Well, you're so kind and clearly doing the right thing with the research that you're doing and the perspective you're bringing to the table. And, collaboration is the way forward in women's health and in all of healthcare. So
absolutely.
Thanks for reminding us of that.
I should probably say, just before I go, is that it's so important. And one of the things we really try and do in all of our research, and I'm sure others do as well, is we have to include people with endometriosis from the community when we design our projects, when we, develop them. And, it's really important at the end to make sure it's translated back into changes in the healthcare system. And that last part is so challenging. But, the first part, we must involve people with endo, in our design, so we're doing things that people prioritize, people want, and it shouldn't be, it shouldn't be researchers researching on people with endometriosis. It should be a co-design, a collaboration.
I love that. So true. Thank you, truly. And truly,
So
thank you for everything that you're doing.
Thank you. Thank you very much.